Good evening, everyone. We are just getting everybody logged in and we'll start shortly.
Good evening, everyone. My name is Leanne Sedone, and I'm the President and Chief Operating Officer here at Suburban Hospital. Thank you all for joining us tonight. And together, we're going to learn about innovations in cardiac care at Suburban Hospital. I've been part of this hospital for over 30 years now, and I've had the opportunity to see our cardiac program build and evolve over time. This evening, you're going to hear from three of our amazingly skilled and caring physicians who enable us to provide life-saving care to our community. I'm incredibly honored to work with them and so grateful to have them here with us tonight. Cardiac health and cardiac care is a really important topic, and it really touches so many. Like some of you, I personally have had a long family history of heart disease and lost a family member quite suddenly to a cardiac event. So I'm glad you're here with us tonight, and we will all learn. It's my pleasure to introduce you now to Karen Bartozzi, and Karen is our development manager for the foundation at Suburban Hospital, but she's also a grateful patient with a personal story of her own. And I'll turn it over to you, Karen.
Thank you, thank you. Thank you. And good evening, everyone, and welcome to Suburban Hospital's The Heart of Innovation webinar. I'm so glad you made a commitment to your health and set aside time to join us tonight. As Leanne mentioned, my name is Karen Bartozzi. In addition to being a member of the Suburban Hospital Foundation team, I'm also a very grateful cardiac patient, perhaps like many of you. Very quickly, I'll tell you how I first came to know Suburban Hospital. Roughly 10 years ago, after fainting in a nearby grocery store, I woke up 4 days later to find myself a patient in the Suburban ICU. I had undergone a 12-hour emergent open heart surgery. After 3 weeks in the ICU, a pacemaker, a zipper scar running the length of my sternum, and 16 prescriptions, I went home to recover. The cardiac rehab program here at Suburban really became my lifeline during this most difficult time. While I was regaining my physical and emotional strength, I knew I had to give back. I began volunteering with a national organization called Mended Hearts, which gives me the opportunity to offer support to patients and families after cardiac procedures and diagnosis. I have also led the cardiac medical yoga program here at Suburban since 2017. And some of you might know I bring my furry friend Gus to the hospital for pet therapy for both Suburban staff and patients. Most recently, I officially became a member of the Suburban staff, and I'm thrilled to be a part of the foundation team. I'm passionate about all things heart, and I can't wait to learn with you tonight. We have a great program planned with 3 amazing physicians, and it's my pleasure to introduce them all to you now. Our first speaker tonight is Dr. Greg Kumkumian. Greg will be discussing advances in structural heart care. Dr. Kumkumian received his medical degree from the George Washington University School of Medicine. He is currently the medical director of the Cardiac Catheterization Lab here at Suburban Hospital. Our second speaker is Dr. Hong-Hung Wang. She will be updating us on advances in cardiac surgery. Dr. Wang is a cardiac surgeon here at Suburban and an assistant professor of surgery at the Johns Hopkins School of Medicine. She attended Dartmouth Medical School and has a PhD from Duke University. Her fellowship at Johns Hopkins included training in mitral valve repair, CABG surgery, both on and off pump, and aortic surgery. Our third and final speaker tonight will be Dr. Zeishan Ahmad. He is a cardiac electrophysiologist and is the director of complex ablations for the National Capital Region for Johns Hopkins Medicine. He is an assistant professor of medicine with the Division of Cardiology at Hopkins. Dr. Ahmad has expertise in arrhythmia management and complex ablation procedures, including both atrial and ventricular catheter ablations. He earned his medical degree from the University of Toledo. He completed a cardiology fellowship at the University of Arizona and an electrophysiology fellowship at the University of Texas at Houston. Thank you to all of our speakers who are ready to share the latest and greatest in cardiac care with us. A bit of housekeeping before we start. This webinar will be recorded and we'll be answering questions following our final speaker. So please be sure to put any questions in the Q&A at the bottom of your screen, and we'll do our best to get to all of them. Welcome, Dr. Kumkumian. The floor is all yours.
Thank you. Thanks for including me in this interesting conversation. I just want to say thank you to the administration, the Suburban Hospital leadership for supporting our program. Next slide, please. So I'm going to briefly go through where we are in the heart catheterization lab in terms of advances in heart cath, coronary angiography, coronary stent, and structural heart procedures. There's been a significant advancement over the past 10 years in all those areas. Next, please. Just to know what is coming, it's always helpful to know what has come before us. Suburban Hospital has a long history of caring for cardiac patients, going back to the Seaport trial, in which we were a participant in this landmark trial to show that emergency angioplasty in people who are having heart attacks at hospitals without bypass surgery at that time do better than patients who get thrombolytics. The open heart surgery program started in 2006 in partnership with NIH. We joined Johns Hopkins Medicine in 2009 and started the structural heart program in 2017 in coordination with our colleagues in Baltimore at Johns Hopkins Hospital. We implanted our first Impella, which is a left ventricular assist mechanical support device, 2018, and we did our first TAVR in 2017. From there, we've advanced almost every few years with new technologies, including closing small holes in the heart, PFOs, and did our first minimally invasive left atrial appendage closure procedure in 2023. Next slide, please. If you could click for thank you. This is a quick discussion about a patient case. It's an 84-year-old, and this is a typical patient for us for the transcatheter valve replacement. An 84-year-old with severe valve narrowing, a class 3 heart failure, which means a patient can't really do much without getting out of breath and having to stop. The patient was considered poor candidate for surgery and underwent a TAVR, transcatheter aortic valve replacement. On your left is us starting the procedure with ballooning, opening the valve, and then on the right, I don't know if you could click that to play the video, it shows us beginning to deploy the TAVR valve itself. And then the next slide. Thank you. And then this is the valve that's been deployed. This is a Medtronic. There are two types of valves in the US, for the most part, Edwards and Medtronic. This is a Medtronic valve. You can see the metal scaffolding, and then on its end, you can see the valve leaflets. And this is an example, this patient, a typical example of patients we take care of in the hospital, replacing the aortic valves minimally invasively. Typically, patients stay 1 day and recover at home for about 5 to 7 days. Next slide, please. Treating aortic valve narrowing with transcatheter or minimally invasive valve replacement is really the core of a structural heart program. And this briefly is a discussion of what aortic valve narrowing is. Typically occurs with aging. The valve becomes calcified and fibrotic. Next slide, please, which puts a significant strain on the heart. Until 2011, when the FDA approved this type of valve replacement, minimally invasive, all valve replacements were done surgically. Now, more valves are being replaced minimally invasively than surgically, although surgical valve replacement is still an excellent option, and we have excellent surgeons who do that surgery. We go from the groin to the heart without incisions and place a new valve inside the old valve, moving the old valve out of the way, and the new valve leaflets take over that work. Next slide, please. In addition to the transcatheter valve replacement as part of the structural heart program, using the Impella or left ventricular assist device, which we put into the heart minimally invasively to help failing hearts as an emergency procedure to help people in advanced heart failure or who need very high-risk coronary angioplasty procedures to support patients through that. Or whether all the way to the right, we're closing small holes in the heart minimally invasively, again, from the vein in the leg, using a small device, a PFO occluder device, to close small holes when appropriate in patients who have these kind of holes, atrial septal defects, patent foramen ovalis, which people are born with. Next slide, please. More recently, we have the cath lab, and Dr. Zishan Ahmed can speak to this because he's one of the operators who does this procedure. An appendage closure device has been used in our hospital, and actually we are doing quite a few procedures of this sort. When you have atrial fibrillation, the major risk with that arrhythmia is stroke, and it's because clots can form in the little pocket you see there on the left slide. When patients are not good candidates for anticoagulants, this procedure, which again is done minimally invasively from the vein in the leg, puts a seal in that pocket, that appendage, therefore reducing the risk of stroke on patients who can't take anticoagulants. Next slide, please. Mitral valve, the other valve on the left side of the slide here shows what happens when a mitral valve leaks, when it's no longer operating normally, causes significant backflow of blood, and this is very dangerous, can lead to heart failure. Often, and my surgical colleagues do excellent repairs of these valve leaflets, but when patients are too high risk for a valve repair, a mitral valve clip is now able to close up this hole or to repair it. And this clip is now being used in Baltimore. We're not doing this procedure at Suburban, but it's through our colleagues that we are finding patients that are appropriate and moving them to our colleagues. Next slide, please. In terms of the heart cath lab, I just wanted to give a little roundabout discussion. We're doing over 1,500 heart caths per year on average, 400 to 500 angioplasties, and 60 to 70 emergency cases a year. Next slide, please. And there are significant advances with coronary angiography and coronary angioplasty procedures. One advancement has been the way we evaluate with CAT scan, MRIs, and more so now with evaluation in the cath lab when doing the procedure. Next slide, please. We can now see into the artery in a way we've never able to see so clearly before with intravascular ultrasound and OCT, which is furthest to the right, where you can see with excruciating detail the actual lumen of the vessel and the plaque that's there and whether there's any calcification. This helps us understand if narrowings are severe and how to treat them. Next slide, please. And this just gives you a nice slide to show the detail that one can see inside the artery with these tools. Next slide, please. We also use a wire called a fractional flow wire, which measures the pressure gradient across narrowings. And this is a very important tool to evaluate blockages when we're doing our procedures. We no longer just rely on the degree of narrowing of a vessel to decide whether it's appropriate to open it with a stent, but we use these physiological tools to be sure that opening the blockage will help a patient. Next slide, please. There's also recent advancements on how to treat blockages in the coronary arteries. Heavily calcified arteries are difficult to treat. In the past, we've used what you might have heard as Roto-Rooter, rotational atherectomy, which is an excellent tool. But now there's a tool called lithotripsy, which has been used in the past for kidney stones, but now is a balloon procedure to break up calcium so that we can open arteries and put stents in them. On the leftmost part of the slide, you can see calcium on a CAT scan, and then the animated pictures to show calcium and the opening of it with this excellent new tool. Next slide, please. So what does the future hold? Well, advancements in how we treat coronary arteries, blocked arteries, and how we evaluate them. And I think most importantly, advancements will come in our lab and in the country and in the world on structural heart treatments, minimally invasive treatments of I showed you for the aortic valve, the tricuspid valve, for holes in the heart, for pockets in the heart that need to be closed. But this is also being further used to evaluate treatment modalities minimally invasively for the other valves, the tricuspid and pulmonic valves on the right side of the heart. Next slide, please. What I wanted to bring up to you as the most recent advancement is something called renal denervation, which we will start doing in our hospital sometime in the next few months. And this is a novel treatment for a resistant hypertension or uncontrolled hypertension. The kidneys are the thermostats in most cases to turn up or turn down blood pressure. And this tool, when used for patients who have difficult to control blood pressure, done again minimally invasively from the groin, putting a tool into the renal arteries where all the nerve innervates and communicates with the brain, has been shown to reduce blood pressure, and by reducing blood pressure, reduce cardiovascular events, stroke and heart attack. Next slide, please. So in terms of the future, we see lots of advancements coming in all the different areas in the cath lab, structural heart, coronary artery disease. And as always, we look for guidance and leadership and assistance from our community and from our hospital. And we look forward to moving forward with advancements as they come to us. And we feel like in a community hospital in our area, we're able to really offer the highest level care anywhere in the world. Thank you.
Thank you so much, Dr. Kumkumian. And as a reminder, there are some questions coming through. We're going to answer all of those at the end. So feel free to load up the Q&A and we'll do our best to get to all of them. And we'll switch gears now and we'll hear from Dr. Wong. Welcome, Dr. Wong.
Thank you. All right, so I'm going to start with an animation of how heart attack happens. As Dr. Kumkumian has alluded to, a lot of patients will come in the first time, they'll come into the emergency room sometimes and they'll have a heart attack. And this is showing you how the plaque builds up inside the artery of your coronary arteries and how the blood flow gets less and less as the plaque builds up. And then at one point, the plaque ruptures and the patient comes in with a heart attack. And nowadays, as Dr. Kumkumian has said, there are many ways we can treat people with blockages in these arteries. And if you can click on the next animation, please. So this is the bypass, and some people have asked me, what exactly is a bypass? Well, a bypass is where we go beyond the area of the blockage. And here's a picture showing you how we take an artery from inside the chest wall of the patient and go beyond where the blockage is to establish this bypass. And we used to do a lot of these bypasses with veins. One of the newer ways of doing this operation is we actually take the native arteries of patients because we found that arteries last longer than veins. So especially for younger patients, nowadays we actually take both of the arteries inside their chest wall, and then sometimes we'll take an artery from the patient's arm. That way, these grafts stay open for a very long time. For example, the internal mammary artery, which we take from inside the patient's chest, that's supposed to last a lifetime. It will not require any re-intervention and will not be blocked. And the radial artery, also the artery from the patient's arm, also has a patency greater than 90% at 5 to 10 years. So these stay open for a very long time, so the patients don't have to have another re-intervention or another surgery down the line. So that's something we're doing. And Hopkins actually, including Suburban, has a much higher rate of patients getting arterial grafts than nationally, because we really want to make sure that patients get the best outcomes long term. Next slide, please. Dr. Kumkumian has explained a little bit of mitral valve disease, and this is a animation showing you how mitral valve disease happens, and this is showing you how blood flows in and out of the heart. And in normal patients, the blood is supposed to flow from the atrium into the ventricle, but in mitral valve regurgitation, the blood actually flows back into the atrium, and that builds up, goes into patients' lungs, and patients present with shortness of breath or trouble breathing, or they have fatigue and exercise intolerance. And that's one of the diseases that's very common in patients, and a lot of patients have this problem. And how we address this problem surgically is we do mitral valve repair. And on the right-hand side, you'll see the picture of how we actually perform the mitral valve repair. We believe that the best thing to do is to do a repair rather than a replacement. And this is very important because patients who get a replacement valve will either have a mechanical valve, which means they have to be on anticoagulation. You have to take a blood thinner for the rest of your life every day and get levels checked every couple of weeks. Or if you get a valve that comes from animal tissue, then the valve does not last a very long time. It lasts about 10 to 15 years, and then you will need a reoperation. But if we are able to repair the valve, then we put patients back as if they've never had an operation. We restore the function of their valve, and we restore the function of their heart. So they go back to their normal lives, and they are on the same trajectory as if they never had an operation. So this is something we try to do in these patients. So you'll see in this picture, we actually create these artificial cords that attach the valve to the heart muscle and anchors them. So this helps where the patients have a leaky valve, this helps bring the leaky valve together, and it helps restore the function and anatomy of the valve. So this is an operation that we do very well, and we are able to, for patients with primary, meaning that the valve is the main problem as opposed to the heart being the big problem, we are able to repair these patients for above 90% of the time. Now, this is not the case across the country. I've recently done a study across the country for all surgeons in the country who perform mitral valve surgery. There is a very big variation in where you go and whether you will get a repair or replacement. So we are able to repair these valves greater than 90% of the time. Across the country, it's about 60 to 70% of the time. So a lot of patients, especially patients who are older, will only get a replacement, and they will not get the benefit of not needing a reoperation and not being on a blood thinner. They will not get that benefit if they are not at a center of mitral valve repair referral, or it's called a center of excellence in this operation. And Hopkins and Suburban, as part of it, is a center for this. So we specialize in this operation, and we do a lot of them, and we are able to help the patients get back to their normal lives. Next slide, please. And the last one I want to mention is aortic aneurysm surgery. And this is, here is a picture showing you where the aneurysm is. The aneurysm is a bulge in the artery, and it can be in multiple locations of the aorta. Now, cardiac surgeons, we treat ascending aortic aneurysm. So this first one where you see it just comes out of the heart, and that's where the aneurysm is located. And we treat this with a replacement of the aorta. And we have a lot of patients who come in with this disease. Nowadays, patients are often getting CAT scans for other disease processes, for example, screening for lung cancer, or getting a calcium scan to see if they have coronary artery disease. And oftentimes they'll find that they actually have an enlarged aorta, and then they get referred to our clinic. So we follow a lot of these patients until they get to a certain size, and then we will treat them with a replacement of the aorta. On the right-hand side is just a picture of how we fix this. And in younger patients who have problems with this, not only an aortic ascending aortic problem, but an aortic root problem, where the problem is where the aorta comes right out of the heart and includes the aortic valve. We are, for younger patients, we're able to actually preserve the valve for them while replacing the root. So that's a fairly complex operation that we are able to do as well. All right. Next.
I believe that's it.
Yeah, I think so. Yeah.
So thank you, Dr. Wong. Of course, well, go ahead, finish.
Yeah, so these are just some of the things we do. We do both on and off pump cabbages where patients may not need to go on the heart-lung machine, and we do mitral valve repairs. We do aortic valve replacements, and we work with Dr. Kunkumian on the TAVR operations, and so these are, and aortic aneurysm surgery. So these are just some of the operations we do. Dr. Kunkumian did mention atrial fibrillation procedures. We also do those for our patients who are getting, for example, getting a bypass operation. We actually will do the atrial fibrillation ablation surgery during the same time if they also have atrial fibrillation, and we are able to place clips intraoperatively during the operation to occlude the atrial appendage as well. And we also do a maze operation, which is we do surgically to ablate the areas that cause atrial fibrillation. And then please
Thank
ask
you
any
s-
questions. Thank you.
Yeah, as a reminder, put them in the Q&A and we'll get to them at the end. Thank you so much, Dr. Wong. That was very thorough and I know a very accurate representation of the cardiac care you can get here at Suburban. So super interesting. Our next speaker is charged up to share his presentation with us. There's sort of a joke when you become a cardiac patient. You realize pretty quickly that some physicians are plumbers and some physicians are electricians. And I think Dr. Ahmad kind of falls into the electrician side of things, which I'm grateful for. So welcome, Dr. Ahmad. Thank you so much for joining us tonight.
Thank you for having me. Appreciate it. I'm getting over a cold, so please bear with me a little bit, but it's great to be here. I appreciate all the organizers for having all of us and, listening to Greg give a wonderful lecture and, all the teamwork that we have with them and then our partners in CT surgery as well, too. So it's great to be here. I appreciate the time to present about what we're doing in EP. I think out of all the fields in the cardiovascular line, it seems to me that EP has really had tremendous change, growth as well too, and I'm very excited to present that to all of you today. Next slide, please. So we're going to kind of start with a real case here. So an unusual case actually, but we were able to take care of it at Suburban just to kind of highlight what we were able to do now. A 23-year-old male with a history of atrial arrhythmias. He had a previous ablation done in 2017 at Children's National down in DC and was referred to me for recurrence of flutter. It was very symptomatic with his atrial flutter and, it was affecting his lifestyle and, a 23-year-old who can't really move around, do anything like that. Obviously, we have all been there before, and that's not something that we want to do. We want to be able to do whatever we want to, have no restrictions, be able to exercise and not have to worry about things like that. This patient had already been cardioverted twice prior to seeing me. He was on Eliquis, which is a blood thinner. He's on diltiazem and flecainide. And so as you can imagine, a 23-year-old being on those kinds of medications kind of just daunting. His thyroid function was normal. His father had a history of MI when he was in his 30s. He went to our genetic arrhythmia center up in Baltimore, led by Dr. Barth. And they weren't able to find any kind of mutation that could represent or kind of be a reason for his findings, essentially. Next slide. So this kind of preludes into our first topic that we're going to be talking about briefly, and that'll be ablation. So if we can go to the next slide, please. And this is just highlighting what's been going on over the last few years, especially with regards to EP and just the dramatic growth that we're seeing in our field and especially at Suburban, especially in the last few years. Our ablation numbers, complete ablation numbers, which is highlighted in the blue box area there, have almost pretty much doubled in the last 7 years or so. As well as the number of devices. We do more devices than Johns Hopkins up in Baltimore. And so that's kind of something that we're proud of, and the fact that we're able to give such quality care and we're efficient as well too. Despite our limitations with our space, we're still able to, double the volume. And it's been amazing to join such a great team that's already been established here at Suburban. Next slide, please. This other slide is to represent the fact that we are very, very good and very, very safe. Our overall numbers with regards to complication rates is much, much lower than the national average, and it's lower than even Baltimore with regards to devices and ablations especially. And so we're very proud of that fact as well too. Next slide, please. So this is our 23-year-old. This is his heart's arrhythmia, the tachycardia, sometimes as some people call it. It is a narrow complex tachycardia. Maybe the umbrella term that some people use might be supraventricular tachycardia. But essentially, this is his atrial flutter. And it's not usually what we think of as a typical atrial flutter. And we'll kind of highlight that fact as we move along. Next slide, please. So this is a 3D representation of the mapping that we do real time. So this is what I do with the catheters. We put wires up into the heart, and we're making this 3D map. And as you can see, what we're seeing right here is this, what we call a timing map. So each sector, each different color represents, anywhere from 10 milliseconds or onward throughout this tachycardia, throughout this heart arrhythmia. And what you can see, if someone can play it one more time, is this pinwheel morphology that we see in the right side of the heart. So towards the right side of the heart is the right atrium, and then toward the left side of the screen is the left atrium. And this map is highlighting this heart arrhythmia, which is localized in an unusual area of the right atrium, kind of along the posterior aspect of that. And he has what we call a micro re-entry atrial flutter. Very, very atypical, very, very rare. And for him to have it after his first flutter ablation is kind of unusual. Next slide, please. And so what we see here is the actual map again, that same location. You can see the propagation map to the left side of the screen. And this is what the data we're actually collecting in real time when we're doing an electrophysiology study. And so to the right, you see the voltage map, and that is how healthy the tissue is. Purple here is healthy. Anything else, the green and the red, are kind of areas of scarring. And if you can see, the flutter kind of goes around that area of scar up there as well too. And if you go to the next slide, please. Oh, back one. There you are. So to the left is the pre-map, and then to the right is the post-map. And what you see with the little red dots are each individual ablation points that we had to do. If you look to the right side of the screen here, you'll see some black dots along the shell there that we call it. And those dots correlate to what we call the phrenic nerve. That's the main nerve that innervates the diaphragm. So if you go somewhere who, they don't do too many complicated cases, they might not know that. And next thing you know, they've ablated the phrenic nerve and the patient has something called a hemidiaphragm. They aren't able to use their breathing muscle at all. And that's kind of a tragic complication that can arise from these kinds of procedures. So you really need to go somewhere where we do quite complex and a high volume of these cases. And so we're lucky that we have that now at Suburban as well too. And this case kind of highlights that. So as we were ablating from that one area of scar to the other area of the scar, the patient's tachycardia terminated. And we can go to the next slide. Luckily hasn't had any more heart arrhythmia since. This kind of lies to the new and exciting phase of electrophysiology, which is a new type of ablation called pulse field ablation. And I'm actually excited to announce that March 17th will be the first day we have pulse field ablation at Suburban Hospital. So we are bringing this technology that is kind of taking over all of EP, spreading across the world actually, and we'll be able to provide this to our patients locally here in March. I won't have to take patients up to Baltimore anymore. I can take their cases and do them down here at Suburban. So what pulse field ablation is it's been around for quite some time, actually. They've used it to deliver chemotherapy agents in the past. And the nice thing about pulse field ablation is that it's specific to a specific type of cell tissue, essentially. And so we can adjust the settings on the catheter to have its effect solely on cardiac tissue. And by doing this, we're hoping that we can minimize damage to the collateral tissue. So esophagus, one of the main complications that could possibly arise from a radiofrequency or a cryoballoon ablation is one of the most dreaded complications, and that's an atrioesophageal fistula formation. And what we're hoping is that by doing this type of ablation, we're pretty much negating that fact completely, 100%. We can also prevent the injury to the phrenic nerve as well, too, because this is just very much specific to the frequency of the heart tissue, and what we're doing is ablating the heart tissue alone. And so what we're causing is not reversible damage to the cell membrane, but we're causing irreversible damage. We're actually killing off the tissue on purpose in order to form scars so that the electrical propagation or the electrical signal no longer goes into the heart anymore to cause the atrial fibrillation or whatever arrhythmia that we'll be able to do with the pulse field ablation. So that's exciting to have. Next slide, please. I don't know if this video will play. Oh, it is playing. Nice. So this is the left atrium. This is kind of the main source of atrial fibrillation. Dr. Kuhn kind of mentioned it as well too. And this is the FARAPulse catheter. This is what we'll be using at Suburban. And what you see is it's giving a 2.5 second shock, which is amazing. Electromagnetic field that's applied to the veins, which are the main culprits for atrial fibrillation about 90% of the time. And what you see is that the catheter can manipulate its shape as such and allow us to really get good areas of ablation along those typical areas that we had to do with radio frequency or cryo. And what we're seeing is that not only are we more efficient, but we're also saving about anywhere from 20 to 30 minutes per case with regards to pulse field ablation. So the first case that I did with pulse field ablation, my ablation time was only 20 minutes. We were done in 20 minutes. It was amazing. Never seen anything like that. And we didn't have to worry about having a temperature monitor in the esophagus. We didn't have to worry about injuring the phrenic nerve or anything like that. And that's all this slide or this video is showing, is that we're sparing all the non-cardiac tissue and we're only ablating the cardiac tissue. So this is going to be a real game changer with regards to ablation, and we're happy to have it down in Suburban. Next slide, please. Kind of now transferring over to the next slide of EP. If it's not ablations, it's devices. And so when it comes to the electrical conduction of the heart, there's kind of three main issues. Usually there's an issue with the main pacemaker cell of the heart called the sinus node. And you can develop something called sinus node dysfunction. Many patients with atrial fibrillation can also have sinus node dysfunction as well. And they may need a pacemaker depending on the situation. Next stage would be atrioventricular or the AV node, and that's the communication between the top part of the heart, the atrium, and the bottom part of the heart. Many of my patients know I usually draw in front of them all the time, and I'm always drawing the SA node, the AV node, and how everything kind of conducts. And they usually take it home with them, and I hope they frame it. I don't know what they do with it, but that kind of highlights the conduction from the atrium, from the pacemaker cells, the main pacemaker cells, down to the ventricles, which are the main pumps of the heart. And sometimes you can develop heart block for various reasons as well too. That might necessitate a need for a pacemaker. And lastly, there's the conduction between the two main chambers of the heart. We call that VV synchrony. And patients who might have bundle branch blocks, left bundle branch blocks, right bundle branch blocks, or other types may need certain types of specific pacemakers that can kind of resynchronize the two sides of the heart in order to promote more abundant cardiac output, essentially. And so sometimes you might have a biventricular ICD or biventricular pacemaker. Those are just two separate wires in two different areas of the heart in order to promote synchrony of the heart once again. Next slide, please. Well, we were doing biventricular pacemakers for quite some time, but then we looked into something new, something called conduction system pacing. And so the idea is that, instead of putting two wires that are arbitrarily pacing the heart and kind of causing an artificial heartbeat to occur, why not use the heart's own electrical highway and putting a wire into that highway? Maybe we can promote heart conduction through that system instead. And so that led to something called conduction system pacing. And that's something that we're doing down at Suburban. Almost all my cases are now conduction system pacing. And what we're doing is foregoing the need for extra wires potentially and replacing that with just one single wire to promote both synchrony from the top part of the heart to the bottom part of the heart, and then within the two ventricles as well too. And what we're finding with the newer and newer data is that we might actually be doing better with conduction system pacing than the more artificial biventricular pacing with regards to resynchronizing the heart once again. Next slide, please. And so this is just kind of showing what a normal heart beat might look like on an EKG. And you might see that a normal heartbeat, the main complex, what we call the QRS, is the main ventricles kind of pumping together. And that's up to the upper left side of your screen in the red section there. And then various, areas of wherever pacing is occurring. So if you have the traditional type of pacemaker, which is the next line, the yellow line, you can see how kind of wide that complex is. And that kind of highlights the fact that it's not really synchronized. The right side of the heart is pacing before the left side of the heart. Thus, we thought maybe if we put two wires into the heart, and that's kind of the third row there. And what we're trying to do is trying to mimic artificially normal conduction of the heart. And what we're seeing is that, yeah, we're doing good, but there are some patients who don't respond to this. And so what do we do? Well, that's where conduction system pacing has come into play. And we can do with one wire what we used to be able to do with two wires, which, not only limits, potential damage that could happen to the wires in the future, potential recalls on wires in the future as well too, but also limits the amount of artificial wires and leads that are in the heart that could be sources of infection in the future as well too. So it kind of declutters the heart as well too, and it's been kind of maybe the most exciting thing to happen in EP in the last 1 or 2 decades since AFib ablation started as well too. So this is kind of an exciting thing, and we have this down at Suburban as well too. Next slide, please. And this is the data just to show that with conduction system pacing, we might not only be able to resynchronize the heart, but if patients who have congestive heart failure have conduction system pacing, their heart function might even improve compared to the old traditional pacemaking system, which was what we call biventricular pacing. So if we can not only help patients with left bundle branch block as well as congestive heart failure improve their heart function through this means, it's an amazing kind of new territory that we're really looking into, and we're really excited about the possibilities as well too. Next slide, please. And this is just showing the data that conduction system pacing seems to be not only non-inferior to biventricular pacing, but probably even superior to it. Next slide, please. The next section would be talking about leadless pacemakers. So as exciting as it is to talk about conduction system pacing, this other feature of pacing, which is leadless pacing, where the entire device is really located in a small little, almost thumb drive size device that goes directly into certain chambers of the heart. You don't have the wires anymore. You don't have the having the generator kind of be there. You don't have to worry about any of those things. And these devices could potentially last up to anywhere from 15 to 20 years at times. And you can see kind of a reference point, there's a nickel right there, and that's how big that micro device is compared to it. So it's amazing what we're able to do now with these pacemakers and patients who we'd be concerned about infections, patients who are kind of bedbound, quadriplegics, patients with renal disease or on dialysis or high risk for infections. If we can put these devices in them instead of having the traditional pacemaking leads and wires, there's less material that could possibly become infected. And so Dr. Wadham was one of the first at Suburban and throughout, I think, the state of Maryland to implant a dual chamber Aveir, which is a 2 pacemaker system made by Abbott that we implant down at Suburban as well as at up in Baltimore as well too. Next slide, please. And that's just going over the patients that are really indicated for these devices as well. Next slide, please. So now coming back to our patient here, after his ablation, he was doing really, really well, but he was still having these occurrences of palpitations and then moments of almost dizziness and almost passing out. And what you see on his heart monitor here, he wore a wearable heart monitor, is he's having long episodes of pauses essentially. And so we proceeded with implanting a leadless pacemaker in him because he's only 23 years old and he doesn't need to have a bulky system. Instead, we can put a leadless pacemaker and he's able to pace only when he really needs to, which is not that often. And the battery life on the device is 20 or so years. So he'll be in his 40s before we have to really worry about having to replace the device. And that'll give him a lot of time to just have a normal life. As a 23-year-old, I'm sure, like I said, we've all been there. We just want to have a nice, happy life and, be able to do whatever we want, exercise, play around and do all those things as a 23-year-old would, and not have to worry that we might pass out or we might, have palpitations and, have to worry about these things. So next slide, please. And this is just us implanting the device into the right ventricle for the patient. And the image to the right is just the chest x-ray afterwards. Next slide, please. It's a minimally invasive procedure. It goes through the femoral vein along the groin. And this is right after we were done with the case. He's already using the pacemaker, as you can see with that one little blip right there in the middle of the EKG. Next slide, please. And then lastly, as Dr. Kumkumian alluded to, is stroke prevention. And so the biggest concern with atrial fibrillation is its risk of stroke. And so blood thinners are usually the ideal agent that we use to decrease that risk of stroke, which increases with various factors. We have kind of a scoring rubric that we use called the CHA2DS2-VASc score. And depending on where you are on that scoring, you may need a blood thinner. And sometimes not all patients can tolerate blood thinners for a long time. And for those patients who can't, These two devices, one is the Amulet device made by Abbott, and the other one is the Watchman device made by Boston Scientific. And the Watchman device is actually on its 4th generation at this point. It's a great device, and we're implanting them, but we're also able to implant the Amulet as well too. And these devices we implant in order for our patients to come off of a blood thinner and hopefully just to a baby aspirin once a day. It's really meant for patients who are high risk for bleeding, patients who might be fall risk, things like that. But we're looking into maybe expanding that with a new trial that we'll be talking about. Actually, I have to give a talk about in a month or so in DC. That we're looking into expanding our criteria for which patients might be eligible for this device. Next slide, please. And this is just a video kind of highlighting how we implant it. We go through the blood vessels of the groin, we go up into the heart. We make an artificial hole from the right side of the heart to go into the left side of the heart. This is that left atrial appendage that Dr. Kumkumian was mentioning is the main source of clotting when patients have atrial fibrillation. And so what we do then is go up with the Watchman catheter, and we go up into that left atrium, and then over time, under fluoroscopic guidance, which is the CT arm, and transesophageal echo, which is the ultrasound, we can kind of guide the device into that left atrial appendage. We make sure that the size is right, that the fit is good, that it's not just going to pop up all of a sudden. And once we meet that certain criteria, then we're able to successfully deploy the device. And then roughly about 6 weeks afterwards, we'll do another procedure called a transesophageal echo one more time to make sure that the device is well seated, that there's scar tissue that is formed around the device in order for us to get our patients off the blood thinners and then onto a baby aspirin at that point. So that's the endothelialization. That's the tissue that is formed over the device. And once that's done, we're able to safely take our patients off of a anticoagulant like Eliquis or Xarelto, Pradaxa, and then put them just on a baby aspirin. And for certain patients, this can be great and amazing device to implant. Next slide, please. And this is just highlighting how everything's kind of favorable towards Watchman compared to an old workhorse for our patients, which is warfarin. Next slide, please. And also, these are just studies highlighting the how it wasn't considered non-inferior to traditional blood thinners with regards to reduction of clotting strokes. And then there was slightly a higher risk of bleeding strokes with the blood thinner, and that traditionally that the patients who had the Watchman devices were doing better with regards to decreasing the risk of bleeding strokes. Next slide, please. Any questions?
Thank you. You made it through, Dr. Ahmad.
I did.
You made it through. Take a break. I have about 10 questions or so. I'm going to kind of send them over to Dr. Kumkumian and Dr. Wong and let you get your give your throat a break. So I think Dr. Kumkumian, I think you talked about this. The question is, can you do a lithotripsy and not place a stent?
Typically, no. The lithotripsy prepares the artery for a stent. The stents are the gold standard for treatment of narrowings with very low risk of re-narrowing. So it's really just to prepare the calcified artery so that a stent can be placed, but not just placed, fully deployed. In other words, open completely to the size of the artery. If you don't do that, then the calcium restricts the stent. The stent can't be fully opened. It's not the size of the artery and has a high risk of failing.
Okay, thank you. The next question, do you do minimally invasive bypass?
I'm going to leave that to my surgeon colleague,
Yeah, Dr. Wong.
Dr.
So
Wong.
there's actually very few people who could have a minimally invasive bypass. It is doable, but you can only really have disease in one artery and to get a minimally invasive bypass. And it's really a misnomer because people still need to have a thoracotomy. So instead of a middle incision that splits the breastbone, they actually have an incision on their right side of their chest, so left side of their chest. So it's actually also a it's still an incision, so it's not really a really a minimally invasive in the sense that, for example, TAVR is where we don't need to open the chest.
Thank you. A couple of you talked about having younger and younger cardiac patients. What ages are considered younger? Dr. Kunkumian or Dr. Wong, I guess.
Well, I mean, I think there's some evidence because of issues of obesity, which increases risk of diabetes, and lifestyle issues, that we are finding younger patients with advanced coronary disease. I think younger would be people in their 40s and 50s having advanced coronary disease or advanced valve issues.
Thank you. Dr. Ahmad, this is circling back to you, and I think you did address this. When will Suburban be getting the equipment for the new type of ablation, the pulse rate? And as part of that, I've read some literature about proton beam therapy. Is that one and the same for
No.
ablation?
No,
it's
proton
different.
beam therapy is different.
Uh-huh.
So that's more of a non-invasive measure of doing ablation, and we're looking into it for ventricular tachycardia, not specifically at Hopkins, but it's being looked at specifically at, I think it was
Mayo, I think, is doing it.
Mayo, Barnes, in St. Louis. Either way, pulse field ablation is still an invasive procedure, and we'll have it available, like I said, March 17th. So our first case will be doing March 17th.
Thank you. I believe this, I'm not sure who could answer this best. Can mitral valve problems cause AFib? Dr. Wong or
Yes.
Dr.
Yes.
Yeah.
Definitely. It's one of the major causes of atrial fibrillation.
It's a good thing there was agreement on that.
I've canceled cases in patients who've had severe mitral regurgitation, who were scheduled for an ablation. I've canceled them and sent them to our surgical colleagues for fixing the heart valve, because without fixing the heart valve, me doing an ablation is really going to be useless, essentially. And so our surgical colleagues they can fix the mitral valve, they can kind of do an AFib ablation surgically as well too, and then they can do the AtriClip too. So hopefully we can get you off a blood thinner potentially as well too. So if it's the right patient, I will send them for surgery instead.
Dr. Wong, are aortic aneurysms routinely scanned for?
They are not actually. Only patients who if we identify a patient, especially if we think they may have a genetic component to their disease, we will ask their family members to be screened, but it's not a routine scan.
Okay, thank you. Dr. Wong, this is from one of your recent patients who's a friend of mine, actually. He says, thank you for the VSARR. What sorts of advances do you think could happen, or do you want to see happen to help with aneurysm detection in the future? Is there a way in the future that we can detect them sooner rather than later with genetic testing or some other method? What's happening?
I'm glad you're doing well.
Exactly.
And I got your Christmas card. It's beautiful. Yes, that's actually what I study in our laboratory. So we have I'm director of our cardiovascular precision medicine laboratory, where we try to study if we've been collecting samples from patients and blood samples and tissue samples, and we're trying to see if there are ways we can predict whether these patients will develop aneurysms and whether their aneurysm will grow, because patients may start with the same size of their aneurysm, but some patients grow at a much more rapid rate than others. And we don't really know how we can predict, because if they don't need to, if they are not going to grow, aneurysms are not going to grow at a rapid rate, then we can follow them for many years, and we may not even need to get a scan every year. But if they're going to grow at a rapid rate, then we want to catch them before they run into problems. So that's something we're actively studying and researching.
Thank you. What happens if a stent becomes completely occluded?
A coronary stent becomes completely occluded?
Yes.
Well, I mean, if it's completely occluded, then it obstructs completely the flow to that artery, to that heart, which could cause a heart attack, just like any other heart attack occurs from occlusion. But the likelihood of re-narrowing within stents in patients who take their medications is very low with modern stents, less than 5%, and it's really lower than that for compliant patients. To have an occlusion would be a catastrophic event. and usually occurs when patients stop taking their medications.
Thank you. If the heart is functioning at 10%, what procedure do you recommend? If the patient chooses not to have a surgery, what other measures can be done to preserve life? Any thoughts on that?
I mean, I think there's just not enough information to know, why is it 10%? Do they have blocked arteries? Do they have a leaky valve? I mean, it depends on the particulars.
Okay. There's a general question regarding diet. I'm curious to know if the physicians are Mediterranean diet or vegan diet, does one hold any more, weight in terms of heart health?
I mean, could you go wrong with either one? I mean,
I know, right?
I mean, I think most people would say, and I'm not an expert at all, that the Mediterranean diet is probably the most studied diet for heart health and has shown the most benefit in terms of heart health. You could argue that, but I think it's a pretty reasonable statement. And I think there was a recent study that came out recently about Mediterranean diet reducing cancer risk. I don't know the details of it, but I think that was recently published.
Dr. Ahmad, curious, what do you know about using Botox for treating AFib?
I haven't read anything about Botox.
You haven't?
We do use it for some certain types of arrhythmias, but they're really transient and they're into it. But I have never heard of anything specifically for Botox for AFib.
Okay. And somebody is asking if stents are still used very frequently. It seems like they are, right?
Coronary stents, sure. Yeah, I mean,
Yeah.
I will say that more recently there's a more cautious approach to using stents because we have more information, more data, more ways to evaluate the flow through arteries. But yes, still used.
And I think we got to all of our questions. So I will pass it off to Cindy Burrs.
Thank you, Karen, so much. I'm Cindy Mers. I'm the Vice President of the Foundation Office here at Suburban Hospital. And I wish I could see all of the participants' faces because I think you probably feel as incredibly impressed as I do with our speakers and with the knowledge that they've shared with us tonight and just with the exceptional care that we are able to offer here. So I just want to, first of all, I want to thank our speakers. I want to thank Karen for moderating and also for doing so many other things to help the cardiac patients at Suburban Hospital with Gus and with the other projects that she has taken on. And then I want to just thank everyone who has taken the time to attend this evening. We're so grateful to have you here, and we're so grateful that you've taken the time to invest in your own health and to learn about some of the things that we're doing here. Having exceptional cardiac care really differentiates Suburban Hospital, and we could not be as incredible as we are without the support from our community. Generous philanthropic gifts from grateful patients and families make an enormous difference. I'm sure that all of our speakers would tell you that there are so many things that they would still like to do, that they would like to bring to the community to be able to bring to patients here. And so if any of you on this webinar are individuals who have supported us in the past, who are among our many grateful patient donors, I just want to take another moment to say thank you for that investment in our programs. We will be sending out a follow-up email in the next day or so, which will include a link to this complete webinar. And we definitely recommend that you share it with others who may be interested in this information and who may not have had a chance to be with us this evening. We will also include a QR code if you would like to link to our website to get some more information about some of the topics that were discussed this evening. And then also, if you have additional questions or would like to somehow follow up with any members of our team or with any members of the panelists and the physicians who were speaking this evening. And so with that, I will just say once again, I'm trying to stay on time because I know you've all invested your time, but with that, I will just once again say thank you to everyone for participating, for speaking, for attending, and wish you all a really good night and really great heart health. Thank you so much.